Hello, I'm Professor Patrick McGorry. Welcome to today's webinar. Before we proceed, as Executive Director of Orygen, I would like to acknowledge the traditional custodians of the land on which we work around Australia and pay my respects to elders both past and present.
Hi, thanks for the opportunity to speak today about how technology can improve the quality of mental health services. My name is Shane. I have a background in clinical psychology, been a service director and a researcher, primarily in the youth mental health space, with an interest in developing technology-enabled person-centered care systems. Problems in mental health services have been well documented. In 2014, the National Mental Health Commission released a report that summarised their findings from the National Review of Mental Health Programs and Services. The report found what countless other reviews before it found, that from the perspective of individuals using mental health services in Australia, the system has a number of negative, fundamental shortcomings that have a direct negative impact on an individual's well-being and productivity. Examples of these shortcomings include poor experiences of care through repeated storytelling, a lack of coordination and care continuity, limited choice, especially for those outside of the capital cities, fragmented services working in isolation from each other, intervention delivered late in the illness course, poor service responsiveness to a wide range of personal needs, and resourcing problems where professionals typically don't work at the top of the skill set or practice, and with an inequitable distribution of skilled professionals across the country. There are particular additional problems in youth mental health services. We know that about 75% of those presenting to Headspace services, for instance, have high to very high psychological distress. And a substantial proportion of those present with diagnostic comorbidity, complexity, ambiguity, and sub-threshold disorders which really challenge evidence-based practice models that rely on clear-cut diagnoses. We know that about 15 to 20% of those young people experience significant symptom or function deterioration during their time in care. We also know that about 1 in 5 will develop worsening syndromes over the 6 to 12 months of their care and go on to develop much more serious mental ill health problems. Additionally, we know that there are long waiting times, especially for back-end specialist assessment and intervention services. And in part, this is due to workforce shortages. Half of all Headspace centres, for instance, report staff vacancies. And then ultimately, for those with complexity, there is a lack of care continuity for those who typically don't respond to the brief interventions on offer. This group of young people have been known as the missing middle that operate between primary and secondary care service provision. So the National Mental Health Commission's report's central recommendation was around developing a system of care that was centred around the person, that more focused on the needs of individuals rather than the preferences of providers, that involved people and their families in key decisions, that helped them navigate the system and provide continuity of care when it was required, that was responsive to a broader set of needs that people present with in their life, and moves away from a system that's overly focused on activity to one that's focused on outcomes. Around the world, definitions of service quality essentially share the same components. Access should be timely, equitable, and available as easy as possible. There should be a focus on keeping people safe by identifying risks and responding appropriately and as efficiently as possible. We need to provide the right kind of intervention, the right intensity of care at the right time. We need to be mindful of not over-treating people or under-treating people. And we need to make sure that there is a balance between the benefits against the risks and or the costs. We need to provide an opportunity for people to be real partners in their healthcare by being involved in the decisions that affect them and treat them with dignity and respect. Importantly, we need to minimise waste, not just the financial and time resources of the clinicians and the services, but we also need to think about the impact on young people, their families, when they have to take time out of school or education or work to travel to services, and the impact that has on their family to help them go to those bricks and mortar services quite often. That has an impact. We need to strive to be continuous and coordinated in the care that we provide, in that care should be provided for as long as it's needed. And we need systems that share information easily between all involved in that young person's care. And lastly, but perhaps most importantly in my view, is that we need services that are focused on delivering the outcomes for which they exist. They need to be defined, they need to be tracked, and they need to be shared with all those concerned. Which brings us to outcome monitoring. It's important to mention that a number of studies have repeatedly demonstrated the importance of monitoring outcomes in care. We know that clinicians just using subjective judgment alone are poor at noticing deterioration in the people they're providing care for. We've seen 12 RCTs, randomised control trials, shown outcome monitoring reduces client deterioration and enhances treatment outcome. And we know that when clients are provided with regular feedback and their clinicians, we see reliable improvements that are about 2 times more likely than when that feedback is not provided. But the value of outcome monitoring is also seen at the service level. Unfortunately, right across the world, systematic and routine methods to measure various aspects of mental health service quality are virtually non-existent. This has been known for such a long time. The World Health Organization argues that reliable and timely health information is the foundation for effective health service management. They went on to say in 2001, nearly 20 years ago, that monitoring is necessary to assess the effectiveness of mental health prevention and treatment programs, and it strengthens arguments for the provision of more resources. We know that access to service quality data can guide evidence-based practice. It can help with performance management, help with accountability, safety monitoring, resource allocation, and overall quality improvement. And we also know that health services that are high quality tend to employ management practices that focus on clinical metrics to set clinical targets and use them to monitor and enhance the quality of the services they provide. So how can technology help solve these problems? Well, the Commission's report recommended that improving access to services and support can be enabled through innovative technologies. The government's response to the Commission's report called for a person-centred care model which targets the needs of the individual, more optimally matches their needs, and does not over or under-service them, but importantly makes best use of the workforce and technology. Which brings us to technology. What is meant by the word technology? I mean, the first thing you think of when we hear the word technology, many of us think about smartphones, tablets, and computers. But really, at the heart of the definition, technology is really referring to the tools and the machines used to solve problems and to do things better, faster, cheaper than before. We've just seen how many difficulties and problems and challenges there are in the mental health service system. So what tools can we use? What tools are at our disposal to solve these problems? Technology is used right now in healthcare, and yet we probably don't define it as technology. We've used the humble telephone for 100 or so more years. Fax machines are common practice in many primary care services and GP practices and are still the predominant way for clinicians to share information between services. Even the therapies and the techniques and the processes that we adhere to, the evidence base, is outlined in books and is also considered technology, so as the humble pen and pad. So while many technologies are tangible, most technologies are really methods and mentalities and a way of using existing tools better to solve problems. So when it comes to technology in healthcare, we are mostly talking about the tools that help us store, retrieve, transmit or share and analyse health, or in this case, mental health data or information. And technology can make the process of storing, retrieving, transmitting, and analysing such information better, faster, and cheaper than ever before, which should flow on to quality improvement. So where software is intended to be used to aid or to itself diagnose, prevent, monitor, treat, or alleviate a disease, including mental illnesses, these are subjected to regulation and are considered software as medical device. Whether electronic medical records fall under this definition is currently being debated, especially as they develop new monitoring and diagnostic capabilities, but at this time, EMRs are information stores only. But in 2019, we need to ask ourselves the question, given how we're surrounded by technology, do we make best use of it? We know that the successful integration of online technology in health services has the potential to vastly improve service quality. It's been well documented for such a long time that the greatest impediment, or one of the greatest impediments to ensuring a high quality system, is the prevalence of 19th century information technologies. And some of those I outlined previously. And unfortunately for the mental health system, not just in Australia but worldwide, it still trails significantly behind the general health system when it comes to collecting and analysing standard health information. There is little agreement about what should be collected and how it should be collected and analysed. So at the Brain and Mind Centre, my colleagues and I have been interested for some time in how clinical research with young people and findings in that area through large databases, data sets, the combination of that with new and emerging health technology and considering service model innovation, how can these three things be integrated to ultimately improve the quality of care that young people receive? When it comes to youth mental health services, we've previously outlined the need to be broader in our assessments and deeper in the depth of those assessments. We need to use that information to better match interventions to need and use concepts like clinical staging to do that more effectively, and not only consider what someone needs at this point in time, but the likely length of care they may require. How young people and their families are involved in those key decisions, not just the interventions they're going to receive or have available to them, but how they're also involved in making other decisions that impact on the quality of their care in terms of when and where they receive those services, for example. We need to make sure that teams are collaborative, that we get the best out of multidisciplinary teams, that we meet regularly, that we use data to centralise our decision making to support each other and get the best out of the team-based approach. And importantly, central to that is the use of outcome monitoring and routine outcome monitoring information and follow-up, central to those processes. And importantly, when you think about how technology can help with all of these things, there is a central role in the integrated use here for technology. In 2016, my colleagues and I at the Brain and Mind Centre, in partnership with the Young and Well CRC, Central and Eastern Sydney PHN, and their 5 Headspace centres, developed and implemented an online assessment and management platform known as the Mental Health eClinic. So through co-design with young people, clinicians, managers and admin staff, an online platform was developed that consisted of a comprehensive online assessment, a dashboard of results delivered to all in real time, and matched recommended apps and e-tools. This integrated technology pathway looked like this. The platform was offered to young people at the point in which they requested a service. They were provided with the opportunity to complete an online assessment at their own time, and algorithms in real time calculated the severity of the needs for which the individuals were responding to, such that when we assessed suicidality, those with high risk received an immediate notification for immediate access to the appropriate care, available 24/7, and the clinician involved in the service was also provided with that notification to follow up and manage that risk as quickly as possible. So after considering their total needs, which was summarised in a dashboard of results, individuals and clinicians then enter into a discussion to jointly decide whether that young person would benefit from further detailed assessment, or whether they should embark on a course of intervention matched to their need, either delivered online supported by a clinician, or access to services available within that service environment. Process is monitored regularly so that information about outcomes can be used to change the level of intervention where required, and the aggregated data, de-identified data, can be available then for the service to provide a much richer data set to allow for better service quality monitoring and resource allocation, monitoring outcomes and other needs. So after a year of implementation in these 5 Headspace centres, 550 young people and 40 health professionals used the platform and reported improvements in access, where need was determined at the point of service request rather than weeks later after an intake interview. These assessments are often completed outside business hours, demonstrating young people's preference to manage their healthcare outside standard clinic hours. Options for apps and e-tools were provided, and young people could match these options against their assessed level of need. Safety concerns were also identified and responded to at the point of service request, rather than again waiting for weeks for an initial intake appointment to determine the level of risk and respond appropriately. Now clearly this reduces suffering and preventing harm in the weeks between face-to-face appointments was a really important finding in this trial. Appropriateness of care was also improved with more detailed information available across a broader set of domains than what would have previously been assessed, helping make more accurate clinical decisions, be they around clinical stage or other treatment needs, and that information can be used with the team to support all clinicians at various levels of experience to guide that question around what is appropriate level of intervention for the needs being assessed. Again, we noticed some efficiency gains in that face-to-face assessments, when they were offered and provided, were completed much more efficiently. This time, 50% roughly, was then able to be diverted to either spend more time, spending more information and getting into the depth of the presenting problem, or being diverted to use to then embark on earlier psychoeducation or brief interventions. And finally, the use of objective and standardised data helped make better shared decisions between the young person and their clinician, as well as being useful in supplementing clinical judgment during team-based treatment planning and clinical supervision. So in all, the use of technology in this way highlighted the potential for sustained improvements in service quality, as well as some of the challenges that needed to be overcome to realise these benefits. Now, there are a number of challenges that we know we need to overcome to make best use of technology. I've listed the 3 biggest concerns. There are others, but essentially those relate and revolve around privacy and security of health information, the clinician and service factors that relate to adaptation and then adoption of the technology, and the issue around the lack of interoperability between IT systems. When it comes to privacy and security, it's important for us to be cognizant of the fact that health information is the most sensitive kind of personal information. Privacy legislation exists to safeguard personally identifiable information against unauthorised use. With the increased use of online health information systems, platforms, apps, e-tools, comes an increased and additional point of exposure to the misuse of personal information. And we know that in the wake of the Facebook scandal, many Australians, many around the world in fact, are very concerned about the use of their personal information for unauthorised purposes. So it's important that before you or a young person shares health information with a third-party digital health tool, it's really important to find out where and how is the data stored. Is it stored in your local country, in Australia for instance, or is it stored overseas, subject to different regulations? Is it in the cloud or on a local server? Are there appropriate consent processes in place? And how thorough is the system in authenticating the identity of the person accessing? Does it mention and does it comply with relevant privacy legislation? And does it also provide links to the relevant privacy regulatory bodies in case of complaints or concern? Is there clear advice about how data is shared, who it is shared with, and for what purpose? And are there details about how the platform manages security and how it protects from unauthorized access from an information cybersecurity point of view? It's important to note that from 2017, individuals and the Office of the Australian Information Commissioner must be informed when there is a data breach that is likely to result in serious harm. One of the biggest facilitators and barriers to technology adoption in mental health care resides with clinicians and service leadership. We know that digital tools are generally underutilised in clinical practice. Where technology is used by clinicians and services, it is usually always because of the internal drive and the personal beliefs of those using the technology. They believe the technology provides more benefits than risks or costs, and then personally are driven to adopt them. But conversely, those with little experience or knowledge of technology tend to have attitudes and beliefs that result in avoidance or limited use. And when the organisations they work for don't have a clearly defined strategy or vision for integrating technology into services, there is also then limited uptake and limited use. We all adopt innovations, including technologies, at different rates. This graph, proposed from Rogers in his diffusion of innovation theory, shows what's known as an S-curve. Now, the S-curve shows that early on, when there is a new innovation or technology, there are a proportion of the population, a small number of people, innovators and then early adopters, who pick up these innovations quickly and are at the forefront of new developments, always looking for new and faster and more efficient ways to solve problems. Once there is some benefit demonstrated, an early majority comes on board and a substantial number then follow, but the innovation is still not mainstream at this point, and this can take a very long time depending on the innovation. It's not until the later majority begin using the innovation that it becomes mainstream and common practice. But even then, there are those known as laggards that take much more convincing before they adopt any change. This graph shows many S-curves for many innovations that have occurred over the last 120 years. I'm sure you'll recognise all of them because they are all considered mainstream today, but as you can see in the past, innovations were less frequent and the population uptake took much longer than it does today. This gave people a long time to adapt their attitudes, their behaviours, in order to adopt and adapt to the new innovation or the new technology. For instance, the community level adoption of the mobile phone and the internet has occurred much more quickly than it took for electricity and for the telephone to become ubiquitous. The 21st century, we are confronted with rapidly changing world with less time to adapt and adopt to these changes and fully appreciate the benefits and take the time to understand those benefits, as well as taking the time to understand and adapt to the cost and the risks associated with using them. So for this reason, leaders in mental health organisations really need to develop careful strategies that support change in their organisations. We need to start with providing personalised training, support and time to clinicians and their service users to increase their knowledge and familiarity with using these new technologies. We need to carefully map out the changes to any work practices that are likely to result from the implementation of such technology, and we need to carefully understand and map out the impact, both positive and negatively, this has on all staff within a practice and young people using services. And importantly, where we see gaps in infrastructure, we need to fill them. We need to make sure, for instance, that we've got secure access to Wi-Fi. We need to purchase updated hardware. We need to do an inventory of what infrastructure is required to make best use of technology. The third challenge to overcome is that of system interoperability, both within and between services. Now, interoperability is the ability of information to be shared across technologies. The lack of interoperability compromises the safety of the individual accessing the service. It impacts on the quality of care and their outcomes, and it ultimately wastes billions of dollars a year worldwide. Now, health services typically have many legacy systems in operation, storing different kinds of health and demographic data used for different purposes. We have EMRs, or electronic health records. We have practice management systems. We have minimum data set software required often from funders. We have apps, e-tools, we have telehealth software, we have external web-based resources and interventions. Now, those that work within clinical systems professionally know this very well, that there is a tremendous amount of duplication and overlap, often requiring double entry, which is a tremendous waste of time and takes away from the precious time required to provide direct clinical service provision in an environment where we are resource poor. But interoperability is not just an issue within a service, it's also an issue across and between services. If we take a different analogy here, we know that we can access our money anywhere in the world, no matter who we bank with. We can also send texts and make phone calls to anybody, no matter what phone network we're on. And yet we can't easily share our vital health information with who we want, when we want to at this point in time. When an individual interacts with multiple health professionals over time, who each use different information technology systems to store that information, individuals are required to repeat their story over and again. Their history and other important data and insights are lost. And the problem with this is that we already know that there is service fragmentation in the mental health system. This is a big problem. But we add to this digitally by creating digital fragmentation, which continues the tradition of poor care continuity and coordination, where vital health information is not readily shared and treatment plans are not coordinated. So logically, this just leads to high rates of error, wasted time, wasted money, and ultimately poor health outcomes. A future mental health care system would enhance connectivity between providers using technology to ensure best care, especially for those with chronic and long-term conditions. So this is one of the driving aims of the My Health Record, and it's had its challenges, especially when it comes to privacy and security. But with the individual choosing what information should be shared with whom, important data will be available to all involved to make better and more personalised and more responsive treatment and management decisions. For this to happen, software providers must work towards common standards for secure information sharing between digital platforms. Improving interoperability is one of the key objectives of Australia's new Digital Health Agency. Which leads us to a vision of the mental health system of the hopefully near future. A future where new tools are developed or old tools redeveloped, with a focus directly on improving health outcomes and quality, not just measuring activity and not just enhancing financial returns for providers. We need a future where health information is secure, is private, where an individual has access and control to that information with the highest standards of privacy and security. We need a future where health information is shared seamlessly with those who are involved in their care regardless of time or place, and importantly, over time. A future where outcome data is accessible and understandable to empower equity and equality in healthcare partnerships between individuals and health professionals, is used to facilitate better professional development and supervision of clinical staff, and is aggregated for use by services, funders, governments to better allocate precious resources and to better monitor quality of services. We need a future where services rethink their approach to the delivery of the care that they provide. A real focus of improving and addressing inequities in healthcare and how technology can solve these problems requires rethinking and redesigning. And importantly, how we provide personal information through staff to manage and adopt these changes. We need to have a strategy and a vision in place to achieve this. So the mental health system of the future will be person-centered, technology enhanced, and it will create efficiencies that allow for more person-to-person clinical interactions and ultimately improve the quality of care for all. Thanks for your time today. It was a pleasure to conduct this webinar. If you have any queries, if you'd like to contact me, if you have any questions or you're interested in our work, please feel free. Thank you.